Hi, my name is John Buse. I'm a professor of medicine at the University of North Carolina in Chapel Hill, United States, where I also direct the Diabetes Center. Since the first ADA EASD Management of Hyperglycemia statement in 2006, I have been a U.S. member of the panel. I had the honor over the last several years to co-chair the effort with Professor Melanie Davies from the United Kingdom. Though generally these guidances have been updated every 3 years, 2019 was a year packed full of really important studies. The committee felt that though our 2018 document was still warm off the press, that it already needed updating, and the American Diabetes Association and European Association for the Study of Diabetes leadership agreed. What I'll try to do for you is take you through the main findings, figures, and comments, and provide a bit of the context and rationale for the update. The 2019 update came with two key overarching changes. Perhaps the biggest change is that now, in appropriate high-risk individuals with type 2 diabetes, a cardiorenal protective agent should be prescribed independently of baseline hemoglobin A1C or the individualized target. In this context, a cardiorenal protective agent would be a GLP-1 receptor agonist or an SGLT2 inhibitor labeled in your country to exhibit such cardiorenal benefits. Secondly, healthcare providers should engage in shared decision-making around initial combination therapy in new onset cases of type 2 diabetes. This advice is driven from new findings of benefit for initial combination therapy with metformin and a DPP-4 inhibitor in the VERIFY trial. In order to assist providers in implementing these recommendations, this guideline update also specifies indication criteria where GLP-1 receptor agonists and SGLT2 inhibitors are recommended. These changes are summarized in the updated algorithm to direct glucose-lowering medication in type 2 diabetes. Whereas before, escalation was recommended only in people who were not meeting their glycemic target, we have updated the algorithm with a new consideration: the presence or high risk of atherosclerotic cardiovascular disease, or the presence of chronic kidney disease or heart failure with reduced ejection fraction. If a patient presents with established atherosclerotic cardiovascular disease, a GLP-1 receptor agonist should be offered on top of the patient's current treatment plan. Established disease includes prior myocardial infarction, ischemic stroke, revascularization in any bed, or evidence of ischemia on a stress imaging study. This is due to the level of evidence demonstrating these agents reduce the risk of major adverse cardiovascular events, or MACE. Patients without established disease, but with established risk factors, can also benefit from the addition of a GLP-1 receptor agonist. Specifically, these are patients age 55 or older with an arterial stenosis above 50% in any vascular bed, left ventricular hypertrophy, and eGFR below 60 milliliters per minute per 1.73 meters squared, or albuminuria. For patients with heart failure or chronic kidney disease, defined as an eGFR between 30 and 60, an SGLT2 inhibitor is recommended to reduce MACE, hospitalizations for heart failure, and cardiovascular death, as well as the progression of chronic kidney disease. Though we provided the opinion that adding an SGLT2 inhibitor to a GLP-1 receptor agonist or a GLP-1 receptor agonist to an SGLT2 inhibitor in patients who need additional glucose-lowering therapy while on one of the cardioprotective agents, there is no direct evidence that the combination provides additional cardiorenal risk reduction. It seems likely to be the case, but it isn't proven. The combination clearly does promote additional glucose lowering without intrinsic risk of hypoglycemia and provides for additional weight loss. Finally, a new recommendation has been added following the results of the VERIFY trial. The trial and other data indicate patients that initiate with dual therapy over metformin monotherapy alone exhibit a lower rate of treatment failure, that is, a loss of hemoglobin A1C control and subsequent increase beyond their target. We now suggest that providers engage in shared decision-making around the initial combination therapy in new cases of diabetes. This has been debated for years, and it's wonderful to have a well-done study to address this issue, enabling us to provide clear guidance. To reiterate, these new guidelines recommend a new approach in diabetes, where cardiorenal protective agents are provided entirely based on the presence of cardiorenal disease or risk, without waiting for the hemoglobin A1C to rise above a target. The new algorithms helps to direct between GLP-1 receptor agonists and SGLT2 inhibitor classes based on the presence of atherosclerotic cardiovascular disease versus either heart failure or chronic kidney disease. And for newly diagnosed patients, clinicians should engage in shared decision-making about whether to initiate with combination therapy rather than metformin alone. Thank you.